Okay, good afternoon, everybody. Once again, in the session, Hot Topics on Breast Imaging. And I would like to welcome you all. And on behalf of the organizing committee, I would like also to give them a very big thanks for such a wonderful organization of such a conference. And of course, with the ISR, we are all pleased to have them with us. So just to go directly, as we are a little bit behind schedule, start our first presentation would be by Professor HEBA AZZAM, and she's Assistant Professor of Radiology at Cairo University. She is a dedicated breast imaging radiologist, and her presentation would be non-mass lesions on breast ultrasound. Dr. HEBA, before we start, I would like to for all the speakers, just please to stick to the time allotted, and for all our wonderful attendees, just please switch off your mobile phone to the silent mode. Thank you very much. Professor HEBA.
Thank you, Dr. Ashraf. Good afternoon, everyone. Today we're going to talk about non-mass lesions on breast ultrasound. The term non-mass finding is not included in the current breast imaging reporting and data system ultrasound lexicon. The current BI-RADS descriptive lexicon for the findings depicted at breast ultrasound includes masses, which are space-occupying lesions depicted in two different projections, calcifications, and associated features. However, radiologists occasionally encounter breast lesions that may not meet the exact BI-RADS ultrasound criteria. Owing to the lack of unified terminology describing these ultrasound findings, non-mass findings have been described using a variety of terms and phrases in the literature, such as vague area of altered echotexture, non-mass image-forming lesions, non-mass-like lesions, and non-mass lesions. The multiplicity of the names leads to variation in recognition and interpretation of these lesions by the radiologist in clinical practice. There are various terms with varying descriptors, but all the studies define a non-mass finding as a sonographic finding that does not conform to a mass shape, thus having non-convex borders. Ultrasound features of non-mass findings. Regarding the echogenicity, it could be predominantly hypoechoic, predominantly hyperechoic, mixed hyper and hypoechoic, predominantly anechoic. Regarding the distribution, it could be focal, which is a small confined area, linear segmental, which is a longitudinal or triangular area along duct distribution, regional, which is a large geographic area not conforming to ductal distribution. Associated features include tubular and/or ductal architecture, posterior shadowing, architectural distortion, and calcifications. In correlation with histopathological findings, it was found that in cases of calcifications depicted on ultrasound images are 3 times more likely to be malignant than those non-depicted. Benign non-mass lesions showing calcifications include fibroadenoma, radial scar, atypical ductal hyperplasia, and tubular adenoma. And malignant lesions include invasive ductal carcinoma in situ, and lobular carcinoma in situ. In cases showing tubular or ductal architecture, though it can be caused by benign lesions, ductal changes may represent the ductal spread of cancer cells. Benign lesions showing non-mass lesions on ultrasound include intraductal papilloma, atypical ductal hyperplasia, atypical lobular hyperplasia, fibrocystic changes, and ductal ectasia. Malignant lesions include invasive ductal carcinoma and ductal carcinoma in situ. In posterior acoustic shadowing, it indicates pathological changing inciting desmoplastic reaction that can attenuate the ultrasound beam. It can be seen in benign lesions as postoperative scar, complex sclerosing lesion, and fibrous or dense breast tissue, or in malignant lesion as invasive carcinoma. Architectural distortion It is due to pathological changes distorting ducts within the adjacent fibroglandular tissue or straightening nearby Cooper's ligaments. It's seen in benign and malignant lesion. However, it is more frequent associated feature of non-mass finding in malignant lesions. It can be seen in benign lesions as fibrosis, sclerosing adenosis, fat necrosis, radial scar, and complex sclerosing lesion. And in malignant lesions as invasive carcinoma and ductal carcinoma in situ. The malignancy rate by architecture of non-mass finding is not known. According to the BIRADS Atlas, the architecture of masses is not a predictive of histopathological findings, and no studies have been performed to establish the prognostic value of architecture of non-mass finding in distinguishing between benign and malignant lesions. Benign lesions that may manifest as non-mass findings are broad. Kim et al. Reported that the most common benign histopathological finding representing 70% of cases in non-mass lesions is fibrocystic changes. Kim et al. Also reported that malignant lesions show more commonly regional distribution with 30%, while benign lesions show more commonly focal distribution with percent of 97.4 compared to 70% in malignant lesions. Park et al. Reported that linear or segmental distribution is much more common in malignant lesion with 45.5% compared to 17% in benign lesions. Non-mass findings are benign in 46 to 90% of cases, with malignancy rates for non-mass finding reported in the literature as ranging from 10 to 54%. Non-mass findings can manifest in both invasive and non-invasive breast cancer, as well as in non-primary breast malignancies. The most common breast cancers identified as non-mass findings on ultrasound images were ductal carcinoma in situ and invasive lobular carcinoma, with 11 to 19% in ductal carcinoma in situ in comparison to 13% in invasive lobular cases. Reported benign and malignant entities of non-mass findings are: the benign entities include normal breast tissue, abscess, apocrine metaplasia, atypical ductal hyperplasia, chronic granulomatous inflammation, diabetic mastopathy, ductectasia, fat necrosis, fibroadenoma, fibrocystic changes, fibrosis, papillomatosis, plasma cell mastitis, radial scar, and sclerosing adenosis. And malignant entities include ductal carcinoma in situ, invasive ductal carcinoma, lobular carcinoma in situ, invasive lobular carcinoma, invasive mixed carcinoma, invasive papillary carcinoma, metaplastic carcinoma, metastasis, mucinous carcinoma, and acute lymphatic leukemia. In this case, we can see a mediolateral, oblique, and craniocaudal mammographic views of a case showing architectural distortion at 6 o'clock. The corresponding ultrasound images show focal hypoechoic non-mass lesion. The biopsy revealed atypical ductal hyperplasia. In this case, we can see a focal hypoechoic non-mass lesion by ultrasound. A biopsy revealed invasive ductal carcinoma. These are ultrasound images of focal mixed echogenicity non-mass lesion, and the biopsy revealed ductal carcinoma in situ. Correlation with mammographic findings. Mammographic lesions that most often appear as non-mass findings on ultrasound images include calcifications, focal or developing asymmetry, and architectural distortion. In this case, we see a focal asymmetry on mammography, and the complementary ultrasound revealed focal non-mass lesion with mixed echogenicity. The biopsy revealed lupus mastitis. Here, we see on the mammographic image an area of architectural distortion with corresponding focal hypoechoic lesion, non-mass lesion on ultrasound, and the biopsy revealed invasive carcinoma with ductal and lobular features and ductal carcinoma in situ. Shetty and Watson reported that 35% of focal asymmetry cases depicted non-mass findings on ultrasound images, while Jesse et al. Found that 53% of developing asymmetries had non-mass finding on ultrasound images. Park et al. Reported that malignant non-mass finding at ultrasound are more often associated with mammographic abnormalities than are benign non-mass findings. as 84% of malignant non-mass findings had corresponding mammographic abnormalities compared with 40% in benign non-mass findings. In this case, we can see global asymmetry with superimposed clustered microcalcification. The AI revealed multiple areas of high probability of malignancy reaching 95%. The ultrasound images showed linear segmental non-mass lesions of mixed echogenicity. The contrast study showed extensive non-mass enhancement, and the biopsy revealed invasive ductal carcinoma. Correlation with MRI findings. An non-mass finding may be a sonographic correlate for an MRI abnormality. In this case, we see post-contrast sagittal T1 and axial subtraction images showing a non-mass lesion, a non-mass enhancing lesion, and on ultrasound there was focal non-mass lesion of mixed echogenicity. The biopsy revealed invasive lobular carcinoma. Wang et al. Reported that ultrasound correlates for ductal carcinoma in situ, which appears as non-mass enhancement at MRI, included vague areas of decreased echogenicity or altered echotexture or non-mass findings. So Tam et al. Found that 40% of non-mass findings at ultrasound have corresponded. So Tam et al. Found that 40% of non-mass findings at ultrasound have corresponding enhancing lesions at MRI, and of these findings, 97% were non-mass enhancement at MRI. In conclusion, non-mass finding may be imaging correlates for mammographic and MRI findings. Non-mass findings are significant as they may indicate malignancy, especially if associated with calcification depicted on ultrasound images. The appearance of non-mass finding on ultrasound images can be subtle. However, suspicions should be raised, especially if non-mass findings are detected on ultrasound imaging in the expected location of a suspicious mammographic or MRI finding. The current published literature of non-mass enhancement provides varied definition and classification systems. Therefore, further studies are needed to validate these categories with histopathological correlation. Thank you.
Thank you, Professor HEBA, for your presentation. I think we will postpone the